may be a little bit different. I was a fellow at the University of Iowa, and Dr. Ronald Lauer was our division chief. My husband is also a physician, and we were trying to put jobs together. We're both pretty subspecialized, so wasn't the easiest thing. And Ron said, well, we'd like for you to stay on, and that would make the job search at that time a bit easier. But he said, you have to bring us something different. And this was probably maybe halfway through my second year of fellowship. And he said, we don't have anybody who's doing this new field of rhythm. And I thought, well, okay. I really hadn't given a lot of thought to it. I was aware of it, and I knew that you could get a lot more information about rhythm abnormalities by putting catheters in, but that was the extent of it. I actually talked with the adult electrophysiologist. It was Dr. Jim Martins at the time. And he said, well, okay, why don't you come spend some time with us? And so actually that's how I got started. My third year of fellowship, I spent several months, I can't remember, it wasn't quite half, but I spent a lot of time on the adult EP service. It was not the easiest thing to do. It was back in the days when really the only thing they were dealing with was ventricular tachycardia, and where they were doing serial EP tests with drug studies to try and prevent sudden death because there were no ICDs. And so a lot of these patients would have 3, 4, and 5 EP studies and spending months in the hospital regulating drug levels. And I really question, what does this have to do? But there were a couple of younger patients, and there were some long QT patients, and that's what really piqued my interest, and I stuck with it. Pediatric cardiology, especially even then, but still, was a fairly small field. And just going to the American Heart Association and talking to other, especially women, who were doing similar things. Vicki Vetter, I had known, she was a resident when I was a medical student. I knew Barbara Deal. Jeanette Strasburger was contemporary. And so just talking with those women, and they said, well, you need to join us. And I said, well, okay, I will. They were a lot of fun. We met at Heart Rhythm, which was also substantially smaller than it is now, and the American Heart Association. We usually had a dinner, and we may have had a speaker, but I don't honestly recall. But it was a group of maybe 20 to 30 people initially, so we knew everybody. It's been a transition to walk into that same thing with the big business meeting now on Tuesday night and realize that I know maybe 10% of the people in the room because I used to know everybody. That's how it really got started. The first big project was probably the catheter ablation, the RF study, and that got its start, just talking about we needed to have a registry and we needed to start to work with NIH to get them to fund this, and that got started in those meetings. I think the biggest question right now for pediatric EP is the issue of genetic disease. And how do we care for these patients? How do we care for the families? I actually just attended this session, and the discussion was, this is a family disease, not an individual disease. We need to work with our adult colleagues because as soon as you identify one person with one of these diseases, you know that you have a huge family to deal with, and to develop that cooperation with the adult colleagues. The second question, the corollary to that, is this burgeoning amount of information that is coming out about genetic disease, and how to understand these genetic tests. I mean, if I had not done medicine, I probably would have done genetics, but the field has just expanded so much that I still feel lost at times. And I often wonder, do we need to even sub-specialize? Do we need to have pediatric EP who deals with the genetic disease, and then what we normally think of as the classic EP who are dealing with devices and ablations and that kind of, because the genetics is just so big. And someone just said in the conference, more genetic testing equals more variants of unknown significance. And how do we take care of that? So I think that's one of the things that PACES needs to deal with. And then you mentioned my work with the Heart Association. I do think when we talk about sudden death, and we talk about the patients who come to us who have been resuscitated, we need to realize that that is an incredibly small proportion of the patients who experience or have sudden death. Nationally, our bystander CPR rates are low. Our use of AEDs in a young population is very low. And if we haven't done that, we're never going to see them. We're going to have to be dealing with a grieving family, and the evidence of what may have caused the death is unfortunately may have been gone already. And so that's the other thing that I think we need to recognize. Those early steps of CPR and bystander defibrillation are really incredibly important for us. I do enjoy mentoring them, and I have taken a special interest in the women. Pediatric cardiology as a field has been dominated by women. The mothers and the grandmothers of pediatric cardiology were Maud Abbott, Helen Taussig, who I had the immense privilege of actually meeting and talking to, Mary Ellen Ingle. We were, pediatric cardiology was founded by women. We often think of Paul Gillette as probably the founder of PEDS-EP, but Vicki Vetter, Barbara Deal, Christine Walsh. There were, again, a lot of women who came to the surface. I think I'd say the same thing, that it's an incredibly satisfying field. You actually can make a difference. When I started with EP, we had no ablation, and in fact, it was also in the early days of operating on patients with WPW. And now we can offer them a cure. It's as much as a cure of anything that we have in medicine. There were no ICDs, and that's as difficult as ICD therapy is. That's still an amazing thing that we have to offer our families. The other thing that I didn't realize when I went into both cardiology and EP was the long-term relationships. Because a lot of these diseases are long-term, our patients with congenital heart disease, and that's just incredibly satisfying. So sometimes as difficult as it can be, because it is a difficult specialty, physically and emotionally, time-wise, it's still just incredibly satisfying. So I encourage them to do it, and say, it does take a bit of time. There's no prize for finishing first. And now that I can look back, I go, well, it really wasn't that much time in the whole scheme of my career.